Thank you and welcome back, everyone, for Mechanisms for Organizational Behavior Change to address the needs of people living with Alzheimer's disease and related dementias. On behalf of the National Institutes of Health and on the panel committee, we would like to give thanks to the National Academies, in particular our meeting liaisons, Crystal Bell, Cheryl Noss, Annalie Gonzalez, Rukshana Gupta, and Lori Brennick. And it is my pleasure now to introduce our final panel. So without further ado, let's get back to Dr. Richard Frank.
Thanks, Teresa. Well, over the last day and a half, we've heard a lot of words and a lot of ideas and a lot of passion and a lot of energy. From that perspective, it's been quite successful. I think what we want to do is we want to end this by sort of reflecting a little bit on what we've heard. And what we've done is we've rounded up members of the planning committee plus a couple of our final panelists in order to help us do that. And I thought I'd start by giving them all each a minute or two to sort of raise up what they see as some of the key themes that have come out and what that means. And then perhaps we come back and spend a couple of minutes on digging a little bit further into a couple of the themes that were raised. So why don't I start immediately to my right with Faith Mitchell.
Okay. I think just high level, one of the things that sticks with me is that, you know, I remember the original scope for the meeting talked a lot about financial mechanisms, but one thing that became clear through the presentations was people saying financial reform was necessary but not sufficient to bring about the kind of organizational behavioral change that we're looking for. And I think our last panel really confirmed that, because we talked about some financial mechanisms, but about a lot more than that. So that's one thing that sticks with me. Another thing is that sustainability point that I brought up, you know, just thinking about, you know, with any change, how do you get individuals and systems to commit in the long term to doing things in a new way. And then my third takeaway is the point about families and communities, and if you know, costs, not only cost savings but also, you know, quality of life, and also just kind of the reality of people with Alzheimer's disease and related dementias is that these things are taking place in communities. How do we support communities? How do we use research to support communities and use systems to support communities so that that care can be done effectively?
Terry?
Thanks, Richard, and thanks for everybody's contribution to this meeting and our wonderful panelists from today as well as yesterday. Exciting work. I think that what I feel across the conversation is a confluence of ideas coming together in a way that I have not personally experienced before when it comes to thinking about caring for people who are affected by Alzheimer's disease and related disorders. And I feel this all hands on deck conversation going on in a way that we come together and build on the work going on across this wonderful continuum of government, of national organizations, of higher education, of all of the different ways that this work is happening. I think that all of us are signaling a can-do moment. We can do this. We can move this forward. We have the mechanisms, and we also have the critical questions for NIA that you've been hearing throughout this meeting funded by NIA. They're asking for your critical advice, and believe me, chat in anything that you haven't been able to say. They're asking you, what is the scientific question in front of us that has to be answered in order to move this work forward? To me, that's the most fundamental thing we can do. As a member of the National Advisory Committee on Aging at NIA currently, we have $4 billion this year in funds to support your research in Alzheimer's disease and related disorders care. Certainly we care about the science of prevention and treatment completely. But now is your moment to say, what are the fundamental questions to guide NIA in this imperative space of what's best for the older individual and their families and their communities? Thank you.
Helen?
So when we started working on some of this NAPA work 10 years ago, we thought, gosh, we don't want this to be the Disease of the Month Club, right? So this month it's Alzheimer's, and next month it'll be whatever disease comes up. And one fundamental truth about this population came out. It's that they're one of the most vulnerable populations, and they are sort of emblematic of everything you want in the entire healthcare system through the long-term care and end-of-life system. And I think that that's an important way to think about this group, this population, and what they need. And a charge to this group is, how do you bring along all of those organizations, because they're all essential to the care of these individuals. So it's not just about changing the healthcare system, although that is an amazing start, but making sure that that is integrated with changing the long-term care system and making sure people get access to high-quality end-of-life care and bringing along the caregivers. So it's not just one organization's behavior change, it's changing this entire ecosystem and how we think really about health and well-being from our 40s on into the end of life. So not a small task that you all have, but important, I think, to bring all of those pieces along in this conversation.
Sarah?
I want to build on Helen's comment, and although it's broad in purview, I think it's absolutely attainable. The importance of thinking about this as a spectrum across a lifespan can't be overemphasized. And I think that one of the themes that I have heard is the importance of changing expectations. So if NIA is looking for research that will show real differences in outcome, changing expectations of care, that cognitive decline is not inevitable, and that managing dementia as a chronic disease where you can get better outcomes across the continuum from mild cognitive impairment to a more significant stage of the disease until end stage. If we change expectations that quality can be good and should be good, and then look to measure the improved outcomes, I bet we'll find that we can do it.
Okay, now we're going to go virtual with Sharon.
Hi, can you hear me? Great, thank you. Just such a wonderful panel, and I'm series of panels and talks, just really amazing, and thank you to everyone. Going through a few epiphanies are moments that really stick with me and stood out for me are when Dr. Shishmani said, or kind of codified, 3 big opportunities for change. And I've been thinking about this a lot since then. So she said, number 1 were the statutes or the policies, right? On the big picture, the 40,000-foot view. Number 2 is the regulatory aspects, or the carrots and the sticks, right? That can either help or hinder implementation of the many brilliant models and programs that we've heard about. And then number 3 is the care on the ground. And so this is, you know, the reality on the ground of where we're trying to make change and how we galvanize that ecosystem. So that was a huge thing that I was thinking about throughout. And then Richard, you made a comment on, okay, we have these great models, but you view them like boutiques. And what we really need is the Walmart, right, that's scalable everywhere. And how do we do that, and how do we achieve that? And I really think it is going to take thinking about all of these three aspects, the policies, the regulatory issues, and then galvanizing and unifying us all, as we're talking about for the care on the ground, to make things scalable, right? We have these wonderful models, and then they don't get implemented. And we've heard like about PACE, right? A model that time and again has shown how it works for the most frail, the most vulnerable, underrepresented communities. And yet we heard about all the obstacles, the regulatory issues and other obstacles that keep it from getting widely implemented. That's just one example, but I thought that that was very telling. And how do we get consistent uptake, right, across states? I think also in terms of flexibility and reach, thinking about more home care options, hospital at home, home-based health services, telehealth, that we can provide, all important areas for research and pragmatic trials that I hope NIA will consider strongly. The support for caregivers, so essential, all the informal care that's being provided, you know, billions and billions and billions in out-of-pocket expenses and time lost from work, and jobs lost because of caregiving is something that's just unconscionable in our country. And then finally, some type of long-term care insurance or payment plan that we need to think about and develop. And I know there's a lot in the works, but really needs to be moved up to the top of our list as a priority. So those are some of my thoughts. Thank you.
Julie?
Hi, good morning, good now. Yeah, so good morning, everyone. I had a couple of sort of overarching themes that I just wanted to reiterate, and then, like Sharon, a couple of sort of moments that really stood out to me that I think is worth just reflecting on and highlighting a second time. So overarching theme number one is equity, is the issues that Alzheimer's disease and related dementias don't affect different racial groups, different ethnic groups the same, and that equity in the research that's funded, really emphasizing who is most at risk, both of having Alzheimer's disease or related dementias and at not receiving quality care or services or support for the caregivers. It just really runs the gamut. So that really, we have to keep that centered. We have to center that equity theme in that work. And the other is the what matters question, which was spoken about a lot in this last panel. We spoke about it in the afternoon panel yesterday as well, that centering what kind of care people get, and whether it's their health care or their social care or their family interactions, whatever it is, that what matters. We need more work around that and how to encompass the different kind of pieces of what matters in what context. I just hear this, and knowing about my own family's experience and other families, you know, so many people that we know have families that are dealing with this issue. Families need a way to navigate this disease. I think about cancer and how fantastic good cancer care programs are that provide a patient navigator. That's a you know, it's not a separate paid service. It's a person that the health system usually pays for, that sits down with a family member and says, okay, now you have this diagnosis, now you have these issues, and here is how things might play out, and here are the different things that you can do. And you know, having a breathing, living person to hold your hand through that process and to just say, it's going to be okay, we're going to figure this out together and we're going to support you, I think is so important, because we've heard that families need information about this disease. They need education, they need care coordination, figuring out how to scale up, like you were just saying, Sharon, the evidence-based programs that have been demonstrated to work in different areas, PACE, the COPE program that I spoke about yesterday, and all of those programs, the home and community-based services, Kate, that you were talking about, Kate McAvoy was talking about, those all rely on us being able to better pay and support the workforce, the frontline workforce, the hands-on workforce, the family caregivers, support, pay if we, as we've seen, those self-direction models have really worked. So that was one, the navigation and paying and supporting the workforce. Other things that stood out to me from other speakers, was lessons that we can learn from other countries and especially from other industries. I thought that Eric Snyder's just observations yesterday, I think it was he who spoke about telemarketing. Like, they know how to find people who have needs, they think, or, Amazon or those industries have found ways that to me was like, oh my gosh, absolutely, this already exists. And so how can we use technology to create algorithms? Sarah, you spoke about the easy button. The primary care providers need an easy button, and so do families. So can we use technology to create an algorithm to develop care plans and education and put some of these things together that already exist but are so disparate and kind of in different spotty places? And then the last area I think is just really important that we haven't actually talked about a lot. It's come up a few times, but we didn't really focus on. I think it's important to focus on, the different stages of the disease, and especially the last stage, the late and end stage. How do we prepare families and individuals for what is going to happen at the end of this disease? How do we integrate palliative care and hospice better for dementia? There's a lot more use of those services in dementia now. But one of the speakers yesterday was talking about the number of live discharges in dementia. It doesn't quite fit, that model doesn't quite fit this disease. And so how do we better align that? And how do we tie that back to what matters? So we see that what matters can really change over the course of the disease. And so we need to integrate that what matters concept as kind of a living, breathing, modifiable, support or theme that travels with people through the whole disease. And there are resources out there that are great. There's a really fantastic book called Making Tough Decisions About End-of-Life Care by Ann Kenny, who's a geriatrician. So just another, I thought that as we had so many things to cover and we covered a lot, and there's more work to be done. And I think that end-of-life stage could use more focus. Thank you.
So we've started off here, very big picture, high level, but both Sharon and Julie have really sort of raised up very specific priorities, and I've been keeping track of ones that are kind of have repeatedly been. So let me just run through those and then give you each a chance to comment a little bit. So obviously scaling was one. And I think it's important to realize that each one of these touches on the points that we were gathered here to take up, which is sort of organization, financing, and regulation, in a sense, in policymaking. So the first one is scaling up. The second one, which is, I think, just a long-term services and support sort of fundamental, is conversations in this area begin and end with workforce. And so I think that there are numerous dimensions to that, but workforce is a broad topic that's very important. Then how to support caregivers, which is sort of the first cousin to workforce in a sense. Fourth is what performance do we want, and how do we go about setting up accountability to yield that performance. Then equity, which was just raised. And then a friendly amendment to what Julie just, one of the things that Julie just raised, which is, in a sense, the convergence of sort of technology in the form of like in-home smart homes and things, but also IT, so that providers and coordination is supported, and then communication technology in a variety of ways. And then finally, there's the end-of-life conversation. So those seem to be like the big themes that that I've heard over and over again here, and it seems like a really good start to a research portfolio for the NIA. And so let me give you each a chance to comment on that, and then we'll declare victory. Well, we go in reverse. When we go in reverse order this time, start with Julie.
I mean, I think you nailed it. You had all of my items and a couple of others, and I love the idea of taking those chunks of content areas and putting them right into a research portfolio. Sounds fantastic.
Sharon?
Me too. I love your priority list, Richard.
You don't have any further reflections on that?
I'm assuming that your performance and accountability item includes measurement, right? Quality measurement and process measurement. Okay.
Yeah, I was thinking that this is a personal observation, which is starting with David Rubin and then going through the rest of the day, when you heard from Eric and the other personal reflections, we got to stop doing bad stuff. I mean, even if we don't know how to measure good stuff, we just got to stop doing really bad stuff. And it seems to me that that's at least a place to start. Yeah.
And maybe we need to make a term for that. Stop doing bad stuff. I totally agree with that. I just want to make sure too that I guess a subheader under every item can be the financial models, right? Or how I want to just make sure that we don't lose sight of that as a priority, but it seems to be cross-cutting, right?
Yeah, I think that's right.
Okay.
I have to go next to follow on Sharon's point. Doing bad stuff is the following. Harm, H-A-R-M, harm. We call it iatrogenesis, we call it harm. It's harm. And so I'd like to make a plea for the National Institute on Aging to fund implementation science, where we can reduce the excessive harm that happens to older people in our system. We know how to measure it, we know what to do. And I am completely enthusiastic about funding work conducted by our implementation scientists, experts in this country, namely the Institute for Healthcare Improvement. Education Development Center is another example. We have the evidence. What we have to do is get it reliably into practice, whether you're practicing in policy or whether you're practicing in a nursing home or whether you're practicing in the community. So I am a complete follower of Don Berwick. I have learned so much from him. If we go back to Crossing the Quality Chasm, just put for Alzheimer's disease and read that report again. Two last points. There was a wonderful book called The Social Transformation of American Medicine. You all read it, Paul Starr. The other one was Strangers at the Bedside by David Evans, who is at Columbia. Both those books chronicle how we got so far away from common sense in primary care in America, where we now have the opportunity to fix it. And we need to do that through science and implementation science. Thank you.
Sarah?
I'm glad to follow Terry, because stopping doing bad stuff, stopping harm is really what I mean by changing expectations. That everyone assumes that an older person is frail and is going to fail, when the answer is not necessarily so. And so stopping the bad stuff starts with changing the expectation that it will. I want to talk about workforce because I agree it's a critical issue. And just like we need more geriatricians and we need more home health care workers and we need more of them who are culturally sensitive and operating at the community level, we're just not realistically going to get those numbers. And so we have to deputize our caregivers by providing them the training when they need it across a continuum of care. And so whether it's early stage or end stage, training caregivers to be equipped to deal with that, which could be a 20-year course, is critically important and just underscores your points about workforce. And then technology, I can't help but tell you all a story about, they're using AI now to detect people who are going to shoplift. If you can determine somebody who is going to go into a retail store and by their gestures and by their movements figure out that they're going to pocket something, surely we might be able to use AI and technology to help older people who are about to fall or about to have a behavioral issue. And I think that in this instance, AI and technology could be our friend.
Helen?
I know I talked mostly about workforce, but one of my favorite policy levers is quality measures. And it is shocking how few policy measures we have for care for people with dementia. I mean, it should be an expectation that people are diagnosed in the early stages. That should be a quality measure. It is not a quality measure. And so I think, what performance do we want from the very earliest stages of the disease progression, and thinking through what it looks like, creating and implementing quality measures that set a high standard for the quality of care that people get. And it's not just, the home health aide showed up or not, which is unfortunately sometimes where we are in quality for home and community-based services. But how do we set those standards very high? How do we measure them? And then how do we set them in policy and practice so that we pay for that high quality care?
And the last word goes to Faith.
Thanks, Richard. So I'm going to focus on your equity takeaway and start with our keynote yesterday that talked about, as I've mentioned before, that Alzheimer's rates are twice as high in the Black community as in the white community, and I think higher in the Latino community as well, and say all the way from mitigation to end of life, is it possible for us to address the needs of families and people living with Alzheimer's in ways that don't reinforce existing disparities in outcomes? So can we actually do things differently?
I think that's a terrific note to end on. I'd like to thank the panelists here, the ones on the screen, and the folks sitting in their offices in their homes. Helen watched us from home yesterday, and thank you all for your attention and your participation, and we're done.